Sure. So thrombosis is one of the most common complications in cancer patients, associated with significant mortality and morbidity. And for about the last 12 or 14 years, the primary anticoagulant to treat thrombosis in cancer patients has been low molecular weight heparins. Low molecular weight heparins have been shown to be superior to warfarin, the old vitamin K antagonist, but provide significant barriers in that they're extremely painful for the patients, extremely expensive for the system, and there's still a fairly high rate of bleeding and recurrent thrombosis. So it's the best we've had, but it's not been the best we can do, at least that's what we've hoped to achieve. So in the last several years, a number of direct oral anticoagulants, or DOACs, have been approved and are available. We've been focusing on Rivaroxaban, and about 2 years ago, we established a clinical pathway at Sloan Kettering to guide use of Rivaroxaban to treat thrombosis in cancer. With these guidelines, we have basically been following a cohort of patients, a 200-patient cohort, who have cancer-associated thrombosis, which would be a pulmonary embolism or a proximal above-the-knee symptomatic deep vein thrombosis. And these patients received their full course of anticoagulation with Rivaroxaban. To make sure that we were doing things well, we track all these patients in a quality assessment, quality improvement initiative. So we're tracking them for hemorrhage, major both, and clinically relevant non-major bleeding, and we track them for recurrent thrombosis as well as mortality. What we've observed in 6 months follow-up, which has now been completed and presented this morning, we've observed excellent safety and excellent efficacy data as well. So our major bleeding rate was 1.6%. And to put that in perspective, from the prior clinical trials using low molecular weight heparins, the major bleeding rate would be about 6%. Our recurrent thrombosis rate was 4.4%. And again, putting that in perspective with low molecular weight heparins, it's usually about 8 or 9%. Now, these are not exact comparisons in that we did a clinical pathway quality assessment initiative as opposed to a formal randomized clinical trial. But a number of observations by ourselves as well as others have now seemed to consistently show that the bleeding rate is between 1.5% and 2%, and the recurrent thrombosis rate is about 4.5% to 5%. So what are we looking at? So for instance, there were a couple of clinical trials called the Einstein studies that led to the Food and Drug Administration approval of Rivaroxaban for treatment of thrombosis. And a subgroup analysis of cancer patients is where we're getting those numbers from. So we're seeing a number of programs, obviously we're most proud of our own, which are showing that Rivaroxaban is indeed a safe and effective choice to treat thrombosis in the cancer patients. So not yet. It's an internal product that we put together. My colleagues and I put it together before we started. And the most important thing is understanding how drugs work. No drug is perfect for all patients, and Rivaroxaban is cleared in the urine, and since it's a direct anticoagulant, we anticipated that if patients had an active urinary tract lesion, such as a bladder cancer or an untreated urinary tract cancer or nephrostomy tubes to drain an obstruction, then there would be a higher risk of bleeding. So we simply don't treat those patients with Rivaroxaban. Similarly, if patients have an active gastrointestinal lesion, for instance, they have an untreated colon cancer or an untreated gastric cancer, then we wouldn't treat them as well. And lastly, if someone has a history of gastric cancer and their stomach's been removed, we wouldn't treat them because obviously they're not going to absorb the oral drug. But when we look at the situations where we recommend against use of Rivaroxaban, it only represents a few percent of the patients. We estimate about 95% of the cancer-associated thrombosis would be appropriate with our guidelines. The guidelines also did recommend dose reduction in the elderly. So people who are 75 years of age or older, we simply used a modestly lower dose. And again, we saw no issues about safety and efficacy following that pathway. So we presented it as a talk this morning. We're completing the paper on this very data set, and we will include those guidelines for publication and dissemination once the paper is written. I'm also very gratified in that a number of my colleagues have asked me for that clinical pathway, and they say we want to do the same thing at our institution, and we're completely comfortable with that. My feeling is the patients benefit. It's a lot easier to take a pill than a shot twice a day, and as long as we're doing that with preservation of safety and efficacy, the more patients that can benefit, the better, and therefore, hopefully, the more institutions that adapt Rivaroxaban and also track safety and efficacy, the more reassurance that we will all have that we're doing the right by our patients. Well, the take-home message, I would say, is qualified in that no one paper, no one project is ever definitive. But clearly, I think we've moved the football down the field, so to speak, in providing reassurance to the patients as well as their providers that use of Rivaroxaban for treatment of cancer-associated thrombosis is a safe and effective choice.